Welcome to AETCM, the emergency medicine channel. Today, let us discuss about one of the common condition which can come to emergency room. It's a headache, that is migraine. So migraine, classically they present with severe headache, unilateral throbbing type of headache. After giving some paracetamol or tramadol or whatever it is, it relieves very fast. It's a common problem. We'll see what is migraine, how do it present, what are the preventive aspects. More than treatment, it requires preventive aspects. So that also we'll discuss. Now, what are the common causes for headache? So, in emergency room, we get various types of headache. One of the common condition is migraine. Other thing is tension headache, then cluster headache. Due to raised intracranial pressure due to tumor, trauma, patient can have headache. Benign paroxysmal headaches, intracranial space occupying lesions, temporal arteritis, especially in elderly individual with thickening of temporal artery, and they can have headache, unilateral headache. Benign intracranial hypertension. So there also that may be due to benign conditions, some tablet overdose. All these things can present benign intracranial hypertension. Systemic hypertension as such can also produce hypertension, especially when the BP is slightly higher than normal, diastolic BP around 100. For a long duration, patient can have persistent headache, but that will be described as a heaviness of heaviness of head rather than headache. Post head injury headache, post coital, that is post sexual contact headache, post lumbar puncture headache is very important. Many patients after lumbar puncture they can have headache. More fluid intake and tilted down position, all these things can relieve some amount of pain. But even then, many patients complain about headache. Sinusitis with sinus tenderness, glaucoma, that's a condition which can produce headache due to eye problem. Many drugs like vasodilators, like especially nitrates, diltiazem, all these things can produce a headache. Amphetamine, alcohol, especially beer intake can produce headache. Trigeminal neuralgia, fifth cranial nerve involvement. Atypical facial pains, post-herpetic neuralgia, that is a severe form of headache, one side of the face because of the trigeminal nerve area, and patient can have severe pain that does not resemble any type of pains what we have described in the previous one. Trigeminal neuralgia and post-herpetic neuralgia have a neuralgic type of pain, constant irritating pain, touching itself can produce severe facial pain. Now, whenever you have a headache patient in emergency room, we should know whether it's a serious problem or it's simple headache like migraine. First time headache, that is very important. Worst headache ever, that is very important. Rapid progression of headache over days or weeks because it's constantly increasing. Whatever we do, headache is not coming down. That may indicate intracranial tumors. Onset of headache after 55. Normally, migraine starts in the younger age group itself. Then they continuously present throughout the lifetime, and their severity does not increase or decrease. Abnormal neurological findings like hemiplegia, visual loss, convulsions, all these things are also important. Fever with headache, that is also important, may be a part of meningitis. Vomiting with headache, that can be due to migraine, but that is also seen in raised intracranial hypertension. Headache induced on bending, lifting, coughing, they all can be seen in migraine, but it can be sometimes severe in due to some other condition like raised ICP. Headache that disturbs sleep, that is very important. Most of the migraine is relieved after a good sleep, but migraine, suppose the sleep is also disturbed, then we cannot straight away tell that is migraine, it can be something else. Presents immediately upon awakening, that may be mostly due to sinusitis. That one of the common feature of sinusitis is early morning headache. Even in hypertension also, we can get this type of symptom. Now, what is migraine? Migraine is the most common cause for headache. It is unilateral, one side or right or left, severe throbbing unilateral headache with photophobia, vomiting. Most of the time, family history will be there. The common forms of migraine are genetically determined, and there are genetic genes involved like KCNK18 and CSNK1D can be there in migraine patients. Now, we have two type of migraine: common migraine and classical migraine. Classical migraine, most of the time patient is having an aura before the migraine attack. Aura can be visual or sensory or motor, like that. Different types of aura will be there. They are mostly sensory, verbal and motor disturbance. Visual disturbance are very, very classical. Zigzag lines in the eyes, black spots in the eyes, flashing in the eyes, and numbness all over the body can be due to a sensory aura. Most of the time, after this aura, patient develops headache, and that is a classical form seen in classical migraine. But in common migraine, these all things may not be there. Patient suddenly develops headache. After sometimes it will become severe, and it will be throbbing and unilateral vomiting may be associated. So cortical spreading of depression can cause aura of migraine. That's a theory behind this one. We will not go to the details of that. You can read about that. So there is something called as aura, and that is due to cortical depression. So that we should understand. Now the headache in migraine is very, very classical. You can see here migraine, unilateral headache, throbbing type of headache, and patient can sometimes vomit also. Okay, these are the classical findings seen in migraine. Whereas you see another important type of tension headache. So it is like a band around the head, continuous pain. Temporal headache, mostly on one side, it is mainly seen because of the temporal arteritis. Elderly individuals are classically seen. Cluster pain is eye pain, redness of eye, watering of eye, severe pain on one side. Hypertension, mostly it is like a heaviness of head. Sinus pain, you can see, or sinus tenderness can be there in many patients. Nasal congestion can be there. So these headaches should be differentiated in emergency room itself. In aura, if it is there, that is a classical feature of migraine. That also we should remember. Now, migraine has got many phases: first phase, second phase, third phase, fourth phase, fifth phase, sixth phase. Like that, it has got many phases, but we cannot, in a patient, we cannot assess all the phases. Most important thing is, most of the patients, or some of the patients can have aura. If it is a classical migraine, then acute attack will be there, then resolution will be there. Postdrom, intracortical, all these things are explained, but we will not go to that. So aura, we have already seen: visual, numbness, visual disturbances, numbness, weakness, confusion, difficulty in speaking, dizziness, vomiting, abdominal pain, all can be there. Acute headache is unilateral throbbing type of headache. Then a resolution with symptoms can suddenly decrease. Symptoms can decrease by sleep. Sometimes vomiting can reduce the symptoms. So resolution also occurs in mostly in same day itself. Very rarely it can continue for many days. Now this chart will tell you what are the common symptoms experienced by various patients, but these symptoms are not seen in single patient. That different presentation of migraine can be there in different patients. Now, there are different types of migraine. When we are discussing about migraine, we can classify there into different groups. Common migraine is without aura. That is the most common migraine. Aura is not there, but headache is there. Migraine with aura, we have seen what are the auras. Migraine sign headache is aura without headache. Only aura will be there, but due to some reason, headache will not be there. Ophthalmoplegic migraine, that is also very commonly seen condition. Patient can have difficulty in moving the eye. So that is mostly due to third nerve or sixth nerve involvement. Retinal migraine, that occurs, otherwise it is called as ocular migraine. Then condition that causes brief attacks of blindness or visual problem like flashing of light in one eye. So this is one of the most important presentation, because these patients can come to emergency room with acute visual loss. So acute visual loss, we know that many dangerous conditions can produce acute visual loss, but migraine is not that dangerous condition. But the advantage is patient will have previous experience about these symptoms. Suddenly patient loses his vision for few minutes, then he regains complete vision back. Sometimes it will be followed by severe headache. So we can consider it as a type of migraine. So this is called as retinal migraine. Now, hemiplegic migraine is another condition. Patient come with migraine with one-sided weakness. Focal weakness is seen in many patients. Focal sensory loss is there, with or without headache can be there. Basilar migraine, it is like brainstem, like any other brainstem stroke. They can have symptoms of brainstem stroke. Migraine equivalents. So many patients will come with abdominal pain, vomiting, vertigo, all these things. But if you examine them, there will not be any finding in the abdomen, or when endoscopy may be negative. That is a type of migraine. It is very difficult to make a diagnosis in that situation. If it is associated with headache, then it is a part of migraine. But sometimes you will not get any headache. So that is also very important. We have already seen the symptoms of migraine. Patient can have nausea, vomiting, unilateral throbbing type of headache, photophobia, phonophobia, sound, light, everything they may not like. Scalp tenderness can be there. There is very common. Cutaneous allodynia is there. Vertigo is one of the important feature of posterior circulation migraine. So many patients will come with severe vertigo and even weakness, nerve palsies, but they are all part of migraine, complicated migraine. Now, visual symptoms, most common visual symptoms, it's come as aura. So they can have temporary visual loss, zigzag line in the visual field, paresthesias, altered consciousness, focal neurological deficit. So these all are complicated migraine. Actually, when you have a migraine, normally they do not have any neurological finding. But if they have a neurological finding, then it will become a complicated migraine. Sometimes we will have to go for an MRI or other imaging technique. Basilar migraine, it is mostly present with vertigo, dysarthria, tinnitus, diplopia, ataxia, visual symptoms, paresthesia, depressed level of consciousness, and hearing impairment. All are cranial, all the symptoms you may get associated cranial nerve involvement. So that is because of the posterior circulation. It resembles sometimes posterior circulation stroke. So that is a problem. So clinically it can produce problem in making a diagnosis. Abdominal migraine, many patients who is having abdominal pain, but that may be a part of migraine. So you can get abdominal pain associated with headache. Sometimes the headache may not be seen at all, only abdominal pain will be there. Retinal migraine we have already seen. Chronic migraine is defined as headache occurring more than 15 days in a month for more than 3 months on at least 8 days per month. So that is chronic migraine. Menstrual migraine, during menstrual periods, patient can have migraine. This is a very classical form, very common form. Many patients, female patients, if you ask the history of headache, they most of the time they tell during the menstrual period days, 1 or 2 days they can have headache. Some says that just before the menstruation also they can get headache. There is no need to investigate, or there is no need to treat that type of patient, because that's part of their life. So they'll have like chronic headache during menstrual periods. Now there are something called as activators of migraine or triggers of migraine. The most common cause is stress. Then female patients especially can get hormonal changes. Skipped meals is another important factor for migraine. So those who are having migraine, they have to take food at regular time. If they skip meals or if they delay their meals, they can have headache. Immediately after taking the food, the migraine mostly it will be relieved. If you take like within 1 or 2 hours, the migraine will be relieved. But if you don't take the meal at all, then the severity of the headache increases. Weather changes can be there in triggers. Excessive sleep or insufficient sleep also can produce migraine. So that is very important. If the patient sleeps more than normal timing, then also you can get headache. Many perfume odors also can produce this one. Neck pain, cervical spondylosis, temporomandibular joint pain, eye involvement, all these things can trigger the migraine. Exposure to light, severe flashing lights, disco lights, all can produce migraine. TV flickering can produce migraine. Alcohol can produce headache in many patients. Sometimes it can lead to migraine. Smoking in some patients it can produce migraine. Late sleeping is very classical. Many patients can have migraine due to late sleeping. Severe heat can produce migraine, and some food materials can produce migraine. Exercise is can sometimes produce migraine, but that is not very common. Sexual activity rarely can also produce migraine. So in all patients with migraine coming to emergency room, normally we don't take any imaging, but there are some indicators that we have already seen red flags in headache. The same red flags here also applicable. Somebody is having migraine or somebody is having headache, we need to take CT or MRI, MR angiogram only if the patient is having these red flags. Otherwise, it is not required. Now, sometimes migraine can become complicated. Migraine can produce migraine complications. Some patients can have chronic bed rest only because of severe headache. Persistent aura can produce problem. Infarctions can sometimes lead to weakness in some patients. Aura triggered seizures can be seen in some patients. So these are the common complications. Now, how to manage migraine? So the most important thing is identify the activating factors and tell the patient to avoid that. That is very important. Patient should avoid the activating factors or trigger for the migraine. Then mild migraine, you can always give paracetamol, aspirin, naproxen or other NSAIDs can be given. Always remember to give antiemetics like metoclopramide with all treatment, because NSAID itself can produce gastric irritation. Migraine also can produce gastric irritation and vomiting. So metoclopramide should be there in all treatment regimes. Now, 5-HT agonist can be given in patients who is having migraine. Ergotamine is one 5-HT agonist that can be given as 2 mg sublingual tablet in acute attack, or 0.5 mg nasal spray also can be given. So, stat you can give, and after 30 minutes you can repeat the dose. So, sometimes it can be like these tablets can be associated with co-formulation like caffeine, belladonna dry extract and paracetamol. So that also can be tried, but that should be given in acute attacks. Now, triptans also can be given. There are different types of triptans. Normally, we give sumatriptan 50 to 100 milligram at the onset, and the repeat can be given 2 hours. Sumatriptan nasal spray also available. Risatriptan sublingual preparations also available. So, triptans also can be given in acute conditions. Now, acute menstrual migraine, almost similar type of treatment. Sumatriptan can be given, ergotamine can be given. Some doctors prefer to give Lasix. That is not given in any textbooks, but some doctors give Lasix to avoid fluid accumulation in the body, but they are not indicated as per standard guidelines. That also you should remember. Other adjuvant therapy, oxygen is very important. Like we should understand what is the mechanism behind the migraine. Migraine normally produces vasodilatation in the brain. When you give oxygen, there will be vasoconstriction in the brain. So that can relieve some amount of headache, but that is also not an indicated treatment. These are offline, off-label treatment. So you can give oxygen. It may give some relief. Sometimes psychological relief also can be given by oxygen. Then magnesium sulfate can be given as an IV infusion. So that has got some effect. You can give 1 to 2 gram of migraine IV, and magnesium tablets also can be continued. And patient should be kept in a dark, silent room. That is very important. Then there are some newer drugs that is not available at present in our country. That is Remegapent 75 milligram can be started. Lasmiditin 50 milligram can also be given, but these drugs are not available at present in our country. Prophylaxis, if there are the number of episodes more than 2 episodes per month with the disability lasting for more than 3 days per month, you can start indication prophylaxis. Prolonged headaches more than 2 days, we can start prophylaxis. Neurological complication also we can give prophylaxis. We'll see what are the prophylaxis. The commonly used prophylaxis drugs are propranolol. This is a beta blocker that crosses the blood-brain barrier. So we can start propranolol as a first-line drug. Young individuals, we can give propranolol. You have to see the ECG. There should not be any heart blocks in the ECG. There should not be any asthma in the patient. So you can start propranolol. Or flunarizine is another treatment of choice that can be given in the night time. Only problem with flunarizine, produces more sleep. So sleep is increased. So young children, school-going children, we cannot give this. There are a lot of other drugs. Topiramate is it's a drug used. Most of these drugs are used in epilepsy. So the same type of drugs also can be given here, like topiramate, lamotrigine. These are anti-epileptic drugs. Sodium valproate. They are all gabapentin. All are used in epilepsy. They can be used here also. And there are other type of drugs like amitriptyline. They are antidepressant drugs. Dotapin is an antidepressant drug. Fluoxetine is an antidepressant drug. So they are also can be used. Verapamil is an antihypertensive calcium channel blocker. They also can be used in migraine prophylaxis. Other newer treatment regimes are botulinum toxin injection can be given in muscles where there is increased spasm, that can prevent some of the muscle spasm, and it may be useful in that type of chronic migraines. So that can be tried in wherever there is tenderness, that can be tried. Opioids normally we avoid because many patients who is taking opioids, they can have chronic dependence on opioids. So we try to avoid opioids, but they give very good relief for migraine. We have to give antiemetic along with opioids, but we try to avoid because it can produce dependence. That is the only issue. Now, other factors we should consider. So, depending on other features like hypertension, patient can have hypertension, patient can have depression, patient can have epilepsy, reduced sleep, obesity, Reynolds phenomenon. So, you can select various types of drugs from the previous chart. So, depending on the associated condition, you can even select, like, so patient is having hypertension with migraine, you can go for calcium channel blocker, you can go for AC inhibitor, you can go for beta blocker. Depression, antidepressives which has got anti-migraine property, like we discussed in the previous slide. We can give epilepsy with migraine, you can go for anti-epileptic drugs. They have both actions against migraine and epilepsy, like valproate and topiramate can be given. Now there are some newer drugs that also can be tried in migraine. We are not going to the details of this type of treatment that can be tried. They are monoclonal antibodies. These are the two devices which can be used for migraine treatment: transcranial magnetic stimulator and vagus nerve stimulation. These devices are available at present in India, so we can try that also. So we have discussed about one of the important problem that can produce headache in emergency room. So when we treat an headache in emergency room, we should know what are the red flags in headache. That is very, very important. We should find out whether that's a serious problem or a benign condition like migraine. If it's a serious problem, then we'll have to go for imaging technique. Thank you.